This lecture is going to be about dementia, and the first thing that I would like to tell you is there are many forms of dementia. Most people think that dementia and Alzheimer's are interchangeable, that, somebody will say, well, he had dementia, and they say, I thought he only had Alzheimer's. Dementia and Alzheimer's are the same, but there's other types of dementia as well. Dementia is basically a condition in which the thinking, memory, and thought processes of a person are compromised. This is a condition that will affect multiple areas of a person's mind and thinking. There are at least 7 areas that dementia affects in an individual. The first is memory. Now, you've heard the short-term memory goes first. This is true in some forms of dementia, but not every form of dementia. It's certainly true in Alzheimer's. It's certainly true in vascular dementia, but it's not true in multi-infarct dementia, and it's not necessarily true in some of the other forms. And so don't be misled into thinking that it only affects the short-term memory first. The cognition. This is the problem-solving, understanding, awareness area of the functioning. Then we have orientation. Now, there are 4 areas of orientation, and we've talked about them. There's the person, place, date, and sensorium. Now, again, when I would work in the hospital, instead of just saying, to a person, do you know who you are? A lot of times I would just grab a chart and ask them, tell them I've got several patients with the same last name, and could they spell theirs so that I would know which one of them that they were? And they'd spell them, and then I'd say, well, if you don't mind, would you please spell your first name, because I've got 2 of that same name. And so that was one way I got them to give me their name. Place, there's no really easy way to test somebody if they know where they are. We would give them cues sometimes, like they know what their name was, but they weren't quite sure where they were, and so we might say, well, do you think that you're in a hospital or a library or a post office? And they might respond like, well, I don't see a long line or a bunch of letters, so I don't guess we're in a post office, and I don't see a lot of books, so I would imagine that this is a hospital. And so we would give them that one with cues. Now, when we're talking about senior citizens and citizens that are a bit elderly, there's no reference point they have for knowing the date. They're not dating checks. They're not at work dating correspondence or different types of paperwork. And so as a result, it's kind of putting them at a disadvantage if you tell them what is the date. And so now we are asking if they know who the president is. Now, my mother was kind of a neat lady here. I'd say, Mother, do you know who the president is? And she'd say, yeah, it's the son of the president that was there before Clinton. And I'd have to think for a second, well, that is true, it's Bush, And so then sometimes I would give her a little cue, and I'd say, Mother, what is it that's called those roses and some of those shrubs are called out in the front yard? I can't remember the word. And she goes, oh, those are called bushes. And she goes, that's the name of the president. And so she was pretty sharp until the last year or so before she passed. Dementia can rob an individual of their personality. It's very, very, very sad. So many times I have seen individuals do absolute 180s of who they once were. Very lovely, sweet, kind, caring people, when they get dementia, become mean and aggressive and assaultive. People that were very pleasant can become grouches. And that's very sad that dementia can do that. Now, an example is a lady that I worked with that was named Tom. She was a patient that came in one weekend, and I started trying to talk to her, and the nurse warned me, because when the nurse did intake, Tom attacked her and cold-cocked her and socked her in the jaw right within the first 10-15 minutes that she was there. She would shuffle through the unit glaring at people, and people would give her wide berth, because that glare, that stare, would have a really, really ominous type of look in her eye, and like she was going to attack at any moment. Now, one day, Tom had some visitors, and as they left, I saw one of them with tears streaming down her face, and I said, well, are you one of Tom's family? And she said, no. She goes, actually, Tom was once a school teacher, and I was one of her former students, and she was the sweetest person. She was loved by everybody, and she always had time for any person at any time. She would come in at 7 o'clock in the morning and tutor anybody that was having problems, and she was the last one to leave every night. She was adored by everybody. She always was pleasant. She was always very loving, and she always had a good word or a hug for anybody who needed it. And she said, to see what this disease has done to her, she said, it's beyond sad. And she goes, I'm just grieving for the loss that this world has had. In speaking about mood, again, dementia not only can cause a person to have mood swings, but it can change a person's mood where they were always known as being a very happy person. Dementia can set in, and they can be a very unhappy or very sad person. It can cause mood swings. And so, again, this is one of the areas that can be affected by this disease. Personal hygiene. As a person progresses with dementia, they will become more childlike. As it gets into the moderate and latter stages, they will be like children not wanting to bathe. They will resist bathing. They also will develop, or I should say, they will not try to remember to go to the bathroom. They'll just go ahead and relieve themselves where they are. So it turns out that this can be a problem with the patients. I had a instance where I came in on a Monday, and I walked up to the nurse and I said, "What is that smell?" I said, "Did somebody poop in the hall?" And she said, "Oh my goodness, I wish that had been it." She said, Your patient Tom came in, and in her hand she had a present for me." And I looked at it and I said, "Oh my goodness," and I went to get some gloves to take the present, and she was insulted that I didn't want to take the present as was. And so she started smearing it different places in the unit. Well, the other patients saw this, and they thought that she had been told something that they didn't get the word about. So every patient on the unit started defecating and smearing it anywhere they possibly could. She said that it was on the ceiling, it was on the floor, it was on the walls, it was on the beds, it was on the bed rails, it was on the toilet, it was on the sink, it was on dressers, it was on wheelchairs, it was on chairs. She said, you name it, they found it and they smeared it. And, you know, again, I'm thinking, you know, this little lady that was so loving and caring, I don't really think that she would have done that and started that incompretic moment had she been herself. Well, also judgment will be affected. Now, seniors in general tend to have a compromise in their judgment and decision-making skills, but particularly hit are the dementia patients. Now, I had a patient one day that the two sisters brought him in, and it was their father, and I asked what they needed to, what they were bringing him in for, and she said, well, before I tell you, she goes, I want to tell you a little bit about my dad. She said, my dad was a very, very shy and private man, very modest. And she said, as we were growing up, the most risque we ever saw him was in a t-shirt with his pajama bottoms. She said he always really wore a robe. He always was completely covered up, and he was very, very emphatic about his modesty. And I said, okay. And I said, so what's going on? She said, we got a call this morning, and our neighbors asked us to come and get Dad because he was doing yard work in the nude. He was weeding, he was planting, he was mowing the yard and raking, and we knew this was not like our dad, and so that's why we're bringing him in. So these are the kind of examples of things that can happen with people when they get dementia. Now, a minute ago I told you there were several types of dementia. One type is called vascular dementia, and it's caused by hardening of the arteries within the brain. Now, they used to call this senility. Old Joe, you know, don't worry about him, he's just senile. That was caused by what we refer to as vascular dementia. Then we have another type of dementia that's caused from multiple strokes, and this is called multi-infarct dementia. Dementia caused by Parkinson's disease is called Parkinsonian dementia. Then there's a type of dementia that hits young people in their 30s and 40s and so. It's called PICS. Now, I've heard it described as a young person's Alzheimer's, but it should be noted that it tends to be an aggressive. The person becomes aggressive and assaultive very, very often, and not only that, but it tends to disintegrate social inhibitions. And so where a person might know not to curse at a certain place, they might blast out with the vocabulary of a sailor, you know. And so this PICS dementia, again, it's another form of dementia, but it certainly is one that should be noted. Tertiary dementia is one that's caused by syphilis. Syphilis is a venereal disease. It is a sexually transmitted disease in which the bacteria that causes the disease, the organisms, they are spiral type of organisms that are called spirochetes. Now, they will enter a body and through sex, and for the first week to 10 days, they're just kind of setting up home. they're getting acclimated to the climate, to the environment. They're reproducing, and at about 10 to 14 days, there will be a very, very ugly, painful-looking type of sore that will appear somewhere on the person's body. Now, as I said before, it will look extremely painful, but from everything I've been told, it is not. Now, after 14 to 21 days, it will just heal up on its own. And the person will say, well, I don't know exactly what that was or what happened, but it's gone, so I guess everything's okay. No, and this sore is called a chancre. And when the chancre heals, that means that syphilis is full-blown, the person is contagious, and the disease is all over the person's insides, okay? They are very contagious at that point. Now, I'm going to show you some pictures of some chancres and show you what I was talking about. This is a picture of a wrist chancre. Now you look at that and you think, how in the world can that not be painful? But I'm told it's not. Here's a chancre on a lip, chancre on a tongue, chancre on a chest, and this is a chancre that's on a finger. And again, like I said, it's hard for me to believe that that is not painful, but I'm told it is not. Now, the only way that you know if you have syphilis is through a specialized blood test. Ladies, unless you ask for this test, the doctor does not do it. Unless you say, I want a test for syphilis, it's not included in your annual physical. Now, one of the bad things about syphilis is for women, the chancre can form within the vagina. It's painless, you don't see it, and so you may not know that you have syphilis. That's why it's necessary that if you're sexually active, and especially with multiple partners, you should be getting a syphilis test every year. For a long, long time, we thought we had syphilis eradicated. We thought it was completely a disease of the past and that there was no cases. It was gone. In the near past, it has made a comeback, a very bad comeback, and the strain now of syphilis is a super strain, and the antibiotics that used to treat it so easily don't touch it, and so they have to hit it with some stronger antibiotics because it's a super bug. Please don't take a chance. If you're sexually active, especially with multiple partners, please get a test at least once a year. If you don't and you have syphilis, it can attack any organ in your body, including the brain. Now, the most famous person that I know of that ever had syphilis was a gangster out of the 1930s named Al Capone. He contracted syphilis from one of the prostitutes that he was visiting, and there was no cure for it at that time, and it set up in his brain and basically ate his brain. He became a vegetable, and they had to let him out because they couldn't care for him. I mean, you know, guards don't have time to change diapers and to hand feed inmates, and so he was not a danger to society anymore, so they released him early. Next thing I want to note is the word Alzheimer's. Please note how to pronounce this. This is a pet peeve of mine, people saying Alzheimer's or Alzheimer's. putting a T in that word. If you'll notice, in this word there is no T, absolutely no T. It is a German word, and if you look it up in the dictionary, it'll have a soft T. But the reason is the Germans would pronounce it Alzheimer's, kind of like AHC, Alzheimer's. Now, we have shortened that and we call it Alzheimer's now. And Alzheimer's is the correct pronunciation. I feel so strongly about this. I've actually called the news anchors in Little Rock and even in New York for the national news departments, asking them to learn how to pronounce the word, because it does not have a T. It is Alzheimer's, and if you'll notice, more and more people are realizing there is no T in it. So, to make a long story long, please note that the correct way of pronouncing Alzheimer's is like it spelled A-L-L, all, Z-I-M-E-R-S, Zymers. Well, in completing this lecture, let's talk just a minute or two about Alzheimer's. I'm hoping that you have already viewed Dr. Amen's film, Change Your Brain, Change Your Life. And I'll tell you why in a minute. When we're talking about Alzheimer's, the person, when they are diagnosed, basically has a 5 to 10 year lifespan. Now, if we were to look at a graph about that lifespan, it would go down like that. If we had a little graph and it was like that, the line for an Alzheimer's patient will go diagonally down very quickly. They go down very quickly, and it's not too long after they're diagnosed that they are going to require assistance, and as they progress, they will need 24-hour care and maybe even more drastic care, considering if they are aggressive or not. Well, if a person has another type of dementia, let's say vascular dementia, instead of having a timeline or a lifeline that goes down so drastically, they will have a line that stair steps. Each one of those steps, those lines on, where the step goes down, that can last days, weeks, months, or years. And so where a person with Alzheimer's may have a 5 to 10 year lifespan, one of those steps can plateau for, say, a vascular dementia person, and they could stay on one step 5 years or longer. Now, why is this important? If you have somebody who is diagnosed with Alzheimer's and they do not have it, they're going to be put on medication that's expensive that they do not need. They are probably going to be put into some facility where they will digress, and it's unnecessary and expensive. And so it's really, really very, very important to get a correct diagnosis of whether a person has Alzheimer's or another form of dementia. This is where the SPECT scan comes in, that I hope that you have heard Dr. Amen talk about. Let's say that you have a grandparent that you love dearly, but you start seeing some cognitive slippage. They're forgetful, they're getting a little confused at times, and you decide to take them to the doctor. Well, the doctor right off ought to order up 3 things: a urinalysis, a blood test. Well, let's just say 2 things right now: a urinalysis and a blood panel. The reason the urinalysis is needed is because many individuals that are senior citizens, it's very easy for them to get a urinary tract infection. Urinary tract infections, when they become what's called septic, can throw symptoms where a person will act like they have Alzheimer's. Their brain will function like they have Alzheimer's. And so, if this is not diagnosed, first of all, the infection will get worse and worse, and that will take them, and they'll die because of that. But the cognitive part will become worse and worse as well. Let's say that the urinalysis is normal. Well, there are some metabolic problems, metabolic diseases that can cause some problems, that can throw some Alzheimer's symptoms. And so the doctor should rule those out. Now, if they get a normal blood panel and a normal urinalysis, the doctor will probably order up what's called an EEG, or electroencephalogram, order up a CT, which is a computerized axial tomography, and an MRI, magnetic resonance imaging. Now, these are great, and that's exactly what he ought to be doing. But sadly, a lot of the doctors are stopping right there. If we could get them, if we could really get people aware of how necessary SPECT scans are, then maybe we could get the doctors to utilize them more. Because when I worked in the geriatric psych unit, we saw a lot of people who were diagnosed with Alzheimer's, and after we did these scans plus a SPECT, a significant amount of patients that were diagnosed with Alzheimer's did not have it. Now, the psychiatrist that I worked with, he said that if you do all those things, the urinalysis, the blood panel, the EEG, the CT, the MRI, and the SPECT scan, that there is greater than an 85% accuracy in diagnosing Alzheimer's, and also ruling out what's not Alzheimer's. And so it's very necessary that we use this. Now, let me give you a story about how really this is so important. I was called up one day by a gentleman, and he said that he had heard that I worked with Alzheimer patients, and he was wondering if I would take his mom. And I said, by all means, and I said, I also like to work with the family when I'm working with the patient. And he said, well, that's fantastic. So he came over, and he brought his mom and introduced her, and very nice lady, very nice lady. And so, I said, well, how long has your mom had Alzheimer's? And he said 7 years. I said, oh, okay. So I turned to the lady and I said, we'll just call her Mary. Mary, can you tell me where you were born? And she turned to her son and said, son, where was I born? I said, no. I want you to tell me. And she goes, well, I have problems sometimes with some of these questions. I said, okay, it's all right. It's not a test. It's just to try and give me some information. And I said, do you know where you were married? And she said, can't remember. And I said, okay. I said, where was your son born? She goes, I can't remember. And I said, can you tell me what your first car was? And she goes, no, I'm sorry. Okay. I said, do you know what you had for breakfast this morning? And she goes, oh yeah. She said, I had eggs, toast, bacon, some cereal, butter for my toast, milk for my cereal, orange juice, and some coffee. And I said, really? And she said, oh yes. And I said, okay. And I said, what do you normally do during the day? And she goes, well, I live with my son and his wife, and so during the day, after they leave for work, I clean up and kind of tidy things, and I'll dust and things like that, and then around noon I'll go ahead and make lunch for them so that they can come home, have a real quick lunch, and go back to work. And then she said when they come home, I'll have supper ready for them. And I said, well, that's very, very interesting. Okay, I'm hoping that you'll pick up a pattern here, hoping that you're seeing some red flags here. So I turned to the son and I said, has she had a SPECT scan? And he said, she's had every test you can imagine. And they had just come from another state. And I said, okay, I'd like to know what the results of the SPECT scan was. And so he said, okay, as soon as I get home, I'll look it up and I'll call you. Well, he called me back a couple hours later and he said, I can't find a SPECT scan. And I said, okay, well, what I'd like you to do is call your family physician and ask if he will schedule a SPECT scan, and let's have a SPECT scan done on her and see what we're dealing with. And he said, okay. Well, the next morning I got a call from the physician, and the physician, whenever you get a call like that, you just know you're going to get reamed out for something, and I was expecting to get reamed out for practicing medicine. And so I answered the phone and I identified myself, and he said, this is Dr. So-and-so. And I said, yes, sir. He goes, I understand you are treating a patient named such and such, which is my patient. And I said, yes, sir. He said, I understand that you want a SPECT scan done on this lady. And I said, yes, sir. And he said, what's a SPECT scan? And I was taken aback. And then I proceeded to tell him what a SPECT scan was and why I wanted it. And he said, well, I've never heard of one. He said, where can I order one? And I said, well, seeing that you're out of town, let me make some phone calls and I'll find out where the nearest one is. Well, I found out, I phoned him back. The lady had the SPECT scan done, got the results a week later, and she had multi-infarct dementia. She did not have Alzheimer's. Now think about this for a second. Here, for 7 years, she had been under the impression that she had Alzheimer's. She had been functioning under that thought of Alzheimer's. Now think about that. Are you thinking every day, well, is this going to be the last day that I really have it together? She was putting out tremendous amounts of money for Alzheimer's medications. There was a lot of things that were going on because of a misdiagnosis. So I told her that she probably really didn't need a therapist or a psychiatrist. She needed a neurologist. And so our psychiatrist gave a referral to a neurologist. And she called me back about 2 weeks later, and she was just as happy as she could be. She called me and she said, I just want to tell you that the neurologist took me off of my Alzheimer's medications, and he took me off of the antidepressant that I was on, which I happened to be allergic to. And she said, I've had a rash for as long as I can remember, and as soon as he took me off that antidepressant, the rash went away. I'm not itching, and a lot of the places on my arm are clearing up. And she said, I just wanted to let you know what was going on, and thank you for, helping us to find out that I didn't have Alzheimer's. Now, quite frankly, that was kind of a rush. But again, just think about that. 7 years, her and her family went through daily thoughts of her having Alzheimer's. Well, Alzheimer's and vascular dementia have a condition in common called sundowners. Now, with sundowners, during the day, they're hitting on all cylinders. You would not know they have any problems. Then right around dusk, there will be a dramatic change. They may have severe memory problems. They may have a mood swing where they were happy and just as friendly as could be around dusk. They'll start turning into mean old men or mean old women and grumpy. Some of them will become aggressive. They may start hallucinating. They may start having delusions. All of these happen right around supper time, whether they've been sleeping all day or awake all day, or sleeping all night or awake all night. We don't know why it hits right around sundown, but it does, and that's how it gets the name sundowners. Well, that's pretty well the end of this particular lecture on Alzheimer's and dementias. As you can tell, you can have dementia and not have Alzheimer's, but you can't have Alzheimer's and not have dementia. With that being said, if you have not seen the Amen film, please do, so that you'll have a much better reference of how important SPECT scans really are. Thank you very much.